This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Let me share with you an experience of a resident surgeon who is implanting probably his first or second CTR in a case which has an intraoperative complication of localized zonular dehiscence. So let's see the video and try to understand what the beginner surgeon experiences while handling a CTR and the problems they face while inserting the ring. The resident surgeon is doing a manual SICS in this case of a mature cataract. The nucleus is mobilized out of the capsular bag into the antechamber, and then it's extracted out using the phaco sandwich technique. So far so good. The surgeon begins his irrigation aspiration, tries to wash off all the debris which are coating the endothelium, and as he begins to aspirate the cortex, he sees there is an area of localized zonular weakness here. So he abandons going to the main wound and tries to go into the side port. And as he's trying to visualize the cortex and see, he realizes that he needs to tackle the zonular dehiscence, otherwise it's going to enlarge and there's going to be a vitreous prolapse. So he is now planning to place a CTR. Of course, this is being done under the supervision of the trainer himself. The chamber is inflated well with the OVD, the posterior capsule is pushed back, and now he's got a CTR, which is a regular size CTR of 11 and 13 millimeter. And now he's beginning to introduce it. Now you can see that the CTR looks very springy in nature, and the surgeon is finding it difficult to judge the consistency, the way it behaves. It keeps on slipping. Let's wait through it patiently and just try to see how things turn out. Now it has, after a few attempts, eventually the CTR can be introduced into the antechamber, and it takes more than a couple of attempts to thread it under the antecapsule. So inserting into the antechamber is relatively easy. Then you have to go under the antecapsule, which is also done quite nicely. Slowly and steadily he's being threading it into the capsular bag, and as 3/4 of the ring has gone inside the eye, now is the time he wants to support it with the second Sinskuk the way I do it. But the surgeon realizes now that he doesn't have a side port because this is a manual spontaneous cataract surgery. So he takes a 23 gauge MVR blade, makes a side port, introduces the CTR to support it, and now he's trying to compress it with the left hand and then trying to maneuver the remaining part of the ring into the eye. So hooking the eyelet with the dialer itself seems challenging for him, but eventually gets hold of it, and the moment it passes under the side port, again he loses it, and now we have a ring which is the one end he's unable to grasp. The option which he had was to use a microforceps, hold it there itself and then negotiate it, and but he wasn't confident of that as well. But the good thing which he did was he never left the left hand. So the majority of the ring was still in the bag itself. And somehow with maneuvering, gradually the ring proceeds in the bag itself, and then again he could go and re-grasp the eyelet with the dialer itself. And then now he's going to position the ring so that the weak area is well supported. And now he's not able to disengage because the second instrument has come out, and he's just going to try and introduce the second dialer once again to disengage the dialer from the eyelet of the ring. But before it does, it spontaneously disengages. Eventually the ring is in the bag and hopefully supporting the area pretty well. But as he was maneuvering, I thought there was a strand which was being tugged at, which could possibly be vitreous, we don't know. But still, it doesn't look very obvious for the trainee surgeon. So he's now going in with implanting the PMMA lens. As the PMMA lens is being introduced, again we can see a strand which is trying to come into the central area from the periphery. Nevertheless, both the distal and the proximal haptics could be maneuvered into the bag, and one good thing is the haptic of the rigid PMMA lens is now in the area of zonular weakness, so it is an additional support to that area. So when the lens was being introduced, I was watching it from the side and I could find that there is something suspicious. So I thought, let me check. So we go in and inject diluted triamcinolone acetate. And the first time it doesn't look obvious. Again, I go in and inject a little bit more of a triamcinolone acetate. And now we can see that the prolapsed vitreous is very well seen. And the prolapse is transzonular from the inferior quadrant, that 6 o'clock area. So time to perform antivitrectomy. So it just takes a couple of minutes to do the antivitrectomy. The prolapsed vitreous is taken care of. I retract the iris with my irrigation cannula and try to go in as peripherally as possible just to engage the vitreous and then cut it. And then I'm going to inject a little bit of pilocarpine to get the pupil down. This also gives us a clue whether we are missing any single strand of vitreous. So it's worthwhile spending an additional 5 minutes to find out any of the remaining vitreous strands, and the single strands can quite easily be missed. So one way to detect is, apart from using the triamcinolone acetate, when we constrict the pupil, if there is a single strand, there would always be peaking in that area. That's the reason why I've used intracameral pilocarpine in this eye. It looks fine and it's time to close. Intracameral antibiotics are placed and the wounds are titrated. The conjunctiva is cauterized. That's it, the case is done. So the message from this case is, you have to practice using a CTR. The beginner surgeon, as we saw, has to get used to the consistency of the ring, the way it feels in the hand. It's a matter how many videos you see. You have to use them in your practice to actually get used to the consistency, the feel, and the difficulties you face through. So my recommendation would be, try to use at least 10 CTRs in routine cases. This is where you get to know the feel and the consistency of the CTR and what difficulties you're going to face. So that was it. I hope you found this useful. Thank you for watching.